traditional owners of the land on which we meet today. And today, on campus, we're here on the land of the people of the Eora Nation, and I pay my respects to their elders past, present, and emerging. And today we're very lucky to have Brett Gardiner here, but what I'm going to do is hand over to Mel Baysari to introduce him. So go ahead, Mel.
Thanks, Adam. And thank you, Brett, for joining us. So Brett is an experienced hospital and healthcare administrator and clinician. I know him because he was the director of clinical governance when I was at St. Vincent's. And I also saw Brett give a fantastic presentation about him leaving his executive role and returning to be a frontline worker. And so that's why I invited Brett to talk to us today. And he's going to be talking about sharpening our approach to patient safety, and particularly the disparity between workers imagined by healthcare executives and workers done by the coalface workers. So I'm very excited to hear the talk, and thank you, Brett. If you'd like questions throughout, if you're okay with that, then I can review those in the chat box if people have questions, if that's all right.
Yep. That's okay, thank you.
Okay, great. Thank you.
Okay, so good afternoon, everybody. I'll just share my screen. So hopefully you can all see that. So I've called this lecture Sharpening Our Approach to Patient Safety 2.0. And the reason for 2.0, as Mel said, was that I gave this presentation 2.5 years ago, and I've pulled out the old slides and have added to it since I've been working back in a management role here at Blacktown Mount Druitt Hospital for the last 3 years or so. And I'm an alumni of Sydney Uni, and have worked as a rehabilitation and aged care specialist and in many different executive roles, including General Manager, Chief Executive, Director of Aged Care and Rehab Services. And essentially during, when I left St. Vincent's, I resigned and went back to clinical practice as a registrar for a 6-month period before being lured out to return to a management role. And so what this talk was originally about and is about today is actually my observations and learnings during that period of time, and also what management can actually do to improve patient safety and bring particularly junior medical officers with them. So the outline of the presentation today, and there's a number of different concepts and things that I will talk about, and you can see that on the slide. Certainly reconciling workers imagined versus workers done, technical versus adaptive change, the definitions of competence, capacity and capability and why that's important to patient safety. The good old patient flow makes an appearance. Is certainly something that I never really considered too much as its impact on patient safety, but it is important. And then how we look at aligning, improving and engaging people to purpose. And then a few different models, and then some lessons and opportunities for research at the end. So this slide here, when I was a couple of years ago, I've got an appointment at AIHI and was working with Jeffrey Braithwaite, and certainly there was published the sharp end and the blunt end. And the sharp end is really at the coalface. That's where doctors, nurses operate. And at the other end, at the blunt end, is, it says on the slide, it's somewhere else. And often it's a long way away from what actually happens at the sharp end. So when we are looking about modernising patient safety, Jeffrey Braithwaite has talked about reconciling workers imagined versus workers done. So a number of you will have worked at the coalface, and some of you may well worked in executive roles, but you will find a lot of the times that people at the coalface have no idea at all what's happening in the administration, the policy makers, the executives and so forth. And on the other hand, the people who are making a whole wide range of policies, procedures, regulations, really don't have any practical insight into what's actually happening at the coalface. So when we go to hospitals, and I've based this talk around hospitals, people need to understand that hospitals are actually complex places where there are lots of people who do different things and often work in parallel universes. So hospitals represent a complex adaptive system. Now, when we start talking about change within a system, and a lot of this talks about change and influence and how you actually bring safety to the fore, is that within a hospital system, it's very hard to look at any individual things in isolation to the systems in place or the lack of systems in place across the organisation. And when we do get complex systems, there isn't a linear relationship between an action and a reaction, or at least even a sustainable continuing on of what the initial initiative was supposed to be. And this is why in systems and that, a number of people apply particular fixes and they won't actually happen or continue to occur at the other end. So the question I've got here, which we're talking about, is how do junior doctors impacted the safety of the hospital system? How does the blunt end appropriately support the sharp end? What works and what doesn't work? How can we best understand and improve junior doctors' role in the safety of the system? Now, for the next 5 to 10 minutes, I'll talk about some of my experience as a registrar within the system. And that was after many years of non-clinical practice and then essentially returning to practice. And my work was in a rehabilitation setting. I went to work basically a subacute facility within a particular ward, and I hadn't worked for a registrar or a junior doctor for over 30 years. I had practiced as a specialist some 7 to 10 years prior to that on a part-time basis. And certainly arriving at the hospital, it was very easy to see that a lot of things were actually going on from day to day. You would get there in the morning, nothing was necessarily ever the same. Even though that I'd come from management, you didn't know or see often what management were actually doing. There were numerous things happening all the time. And to try to actually get into a routine and pattern of what you would do for the day was often complicated by a deteriorating patient or being called away to something else. So it certainly, at the coalface is a very dynamic environment. And I should say one of the things which people laugh at and I laugh at now, my first day when I went to work at the facility as a registrar, well, I didn't know any of the patients, didn't know anybody. And the first thing I did was go and look at the policies and procedures and look at the fire evacuation plan. And that's something that most junior doctors would never actually do. It was what I was used to doing rather than actually looking at what was actually occurring. So a few reflections on my work as done and safety in action. So each day I'd go to work, and thing is I was there looking after the patients, wanting to make sure that I was able to get back into things, and I saw numerous different things. So into reporting on the front line, certainly a blunt instrument or an instrument that's put into all facilities is IMS reporting. And I have to tell you that a lot of time was spent by IMS by the frontline nurses, often 20 up to 30 minutes reporting various things without people really knowing, what they were actually reporting. I remember one occasion, for instance, where a nurse had taken somebody's blood pressure, which was just under 100, and came to see me to tell me because it was in the yellow zone. And I said, oh, okay, what's their pulse rate? I didn't know, so she had to go back and actually check the pulse rate. And then I said, well, what do you think might be causing the low blood pressure? Go and take it again. And that time the blood pressure was up. But she'd proceeded to look at writing a notification and IMS report into this for this person's low blood pressure. And of course, they'd just taken their medications at a different time a little bit earlier. And really it was nothing, but you got a reaction in terms of somebody reporting something that was abnormal. And normally you wouldn't put those into an IMS system in any case. The second reflection was a medication error that I made myself. Now, having been a director of clinical governance and taking executive roles, I've got to say I was absolutely mortified that I'd made a medication error. It was an error that I picked up myself. And the medication error was that I started the wrong person on warfarin. And what had happened is that the medication charts were mixed up when I was actually writing them up. Because in those days, this was even a couple of years ago, this wasn't in electronic systems, and you'd spend a lot of your times copying charts. Now, this occurred because I was sitting down, multitasking, numerous different distractions, and numerous people coming to me to write up different medications, and as one of the things I was doing. And unfortunately, I wrote the notation on the wrong person. One of the things that happened with this was that management decided that one of the things that would help would actually to put up a system about putting the medication charts in a particular location at a particular time of day. Thing was, that was done without any consultation with myself, and yes, like that initiative lasted for about a day or two and then went by the wayside because it didn't align with standard work practice. Really, the way that you could have actually avoided that medication error was being able to be seated in a particular environment, not multitasking with one task at a time. Another interesting one was that each morning you'd come to work and the nurses would have a list of what happened overnight in a book. And oftentimes they'd say patient in bed 3 or patient in bed 6, this had happened or that happened, but they didn't actually put the individual's name. And oftentimes that moved the patient overnight into another room and you had no idea which patient that they were talking about. So one of the things that I did was I drew up on the book, just put a line on the left-hand side, and that was for the patient's name, and I labelled it patient name, and then for them to write the details on the other side. And guess what? That actually worked. That they actually wrote the patient's name, also wrote the bed number, and that was easy for me to find. But of course, what happened was that if I didn't line up all sections of the book, nobody else ended up lining up the books and they went back to just the bed numbers. So that's just an example of a simple intervention that can improve safety and then how you can actually carry things forward. And the last reflection that I want to share on this was, I remember going to an M&M meeting, and certainly I've chaired many RCAs and M&M meetings, and I remember going to one in particular where looking at the incidents on the ward. I've got to say, this isn't a criticism of any of my colleagues I was actually working at, but they went through each of the falls, incidents and all the rest, and what was apparent was that there was a lot of value judgment that was being done on the individual patients about different consequences and things that actually happened to result in that fall. And of course, I actually challenged people, and I was working on the frontline end. Really, what was happening in practice was that any of the standard operating procedures that you had, like identifying somebody as a falls risk, making sure that they had their orientation, all the things that are listed in guidelines, weren't actually routinely happening. Yet we were having an M&M meeting, which was spending a lot of time not looking at the various things that needed to be in place and audited, and looking at other reasons why somebody might have fallen without any outcomes. So a few lessons from that was that some magic bullet solutions really aren't effective over a longer term, particularly in complex adaptive systems. Certainly we found that staff didn't understand the rationale for a process that was put into place, not linked to the purpose. There was often a lack of critical thinking when people were undertaking particular tasks, and the processes were undertaken without any consideration of what could have been the cause of something for which an incident was written. Another occasion was somebody missed their medications that morning, and the thing was, I knew that was the case on 3 occasions that morning, which had been said to me because they had a new agency nurse on that morning and nobody turned up. Yet the person writing the incident form didn't know about that, or didn't inquire to be able to say, well, it'd be good that anybody comes in, we take them through what's actually going on. So I want to just move on to the issues of competence, capacity and capability. And I'm not sure if too many people have actually really considered this, but the question I've got is, should the blunt end focus on the capacity of individuals and systems, or on the competence and capability of the individuals? Now, what I mean by this is that, and you can take any workforce that you like, are they competent in what they do? Do they have the skills, training, abilities to actually undertake a particular role or function? What's their capability in terms of being able to deliver? And what is their capacity? So you may have somebody who's very competent and very capable, but they don't have any capacity to actually undertake the tasks or functions of what is actually needed. Now, for this, for instance, we have a number of people who spend a lot of the time, junior doctors, either chasing around records or notes, trying to find a patient, wandering around big hospitals trying to find things, being able to spend not so much time with the patient, but just trying to organise things. So even if you've got somebody who is actually highly skilled, trained and capable, they may not be able to affect that in the real environment. So what's important with this is that one of the things, certainly from a management point of view, we do need to strengthen individuals' orientation, education and training. But certainly one of the lessons for me and what I've worked on over time is actually to improve the capacity of the workforce to be able to do their standard job. And these things go from IT systems that may help to streamline work, not necessarily to complicate work, which sometimes they do, but if you've got good IT systems, you may well be able to save people's time. And I can give an example. Recently, we set up here at Blacktown the first totally electronic discharge script, which managed to reduce the time taken for pharmacy to deliver a script by 30 minutes compared to the benchmark time. And a lot of the time saving with that also was that prior to this, the doctor had to put the meds in, write a script, sign the script, and either fax, take, or send it in some other ways to pharmacy. Other things to enhance capacity is redesigning to eliminate workarounds and shortcuts, obviously optimising the working environment where people aren't distracted, and other activity controls to reduce demand. Now, the second reflection is on patient flow and the impact on safety. So if you work in a major hospital system, often all you hear about is patient flow, access block, ambulance offload times, all these sorts of things. And certainly at the coalface, you can be quite distant from that. But patient flow presents itself in numerous different ways. Certainly in the environment I was working on, I found that early consultant rounds would often delay the patient discharge unless the paperwork, scripts, medication could be completed prior to the round, which was often difficult to do if the round was starting at 8:30 and you were scheduled to start at 8 a.m. I did manage to do that a few times to actually discharge multiple patients before midday, which was one of the things I always thought, could this actually be done? But it was difficult to routinely achieve due to what was happening each day. The unit I worked split admissions into two teams, and if the team discharged more patients, it received more admissions so that each team would actually be even. One of the things was that my team managed to turn through the patients quicker. So I ended up getting a lot more patients coming through. But there was no load levelling of admissions from day to day. If you discharged 4, you got 4 new patients in. And what happened there was that these admissions would come in at any time, wasn't predictable, depended on patient transport, and that resulted in poor, fewer or delayed multidisciplinary assessments. One of the worst was patient came in late, hadn't been appropriately stopped and seen, fell over, broke the hip and had to go back to sender. But this was certainly the rhythm of the ward, how that worked would certainly impact on safety. I've put this slide up here with a conference that I went to, the Quality and Safety Healthcare Conference in Melbourne in 2018. And the Cincinnati Children's Hospital presented a great presentation, saying that you can't work on safety if you're not addressing patient flow. And things clicked for me and said, yeah, that's exactly right. You need the right patient in the right place at the right time with the right levels of skills, training and expertise. Really, a lot of our hospitals have lots of outliers, and we do rely on not just, we rely on a lot of things, including for communication, including informal communication, which is much easier if you know your colleagues on a ward and you have not just formal discussions, but informal discussions. But it is a precondition for safety. People know that, but it is actually important. Next section I just want to talk about is for purpose, and the guru of a lot of the safety and quality movement has been Don Berwick, and he is quoted as saying the source of energy at work is not in control, it's connection to purpose. Now, a number of standard organisational purpose and goals relate to these 4 things: patient safety, which is 0 harm, high patient satisfaction, efficient resource management and optimal patient flow. Now, when we're looking at junior doctors or the workforce, oftentimes they may look at trying to do 0 harm patient safety, but you don't normally see a lot of junior medical staff or doctors in particular necessarily focusing on the other organisational purpose and goals such as satisfaction, patient satisfaction, resource management and flow. patient safety is often important, but it's from a particular point of mind. Now, this is an important slide in that for those who are interested in lean healthcare, purpose, process and people, to me this is absolutely fundamental in the way we actually consider management approach. Purpose is where we're setting ourselves. We need to align the processes with the purpose, do improvement, people with the process, and certainly engage people to the overall purpose for the organisation to get results. That we always talk about medical engagement, and you go, well, how do we get the medical people engaged to the purpose? The question is then, what is the purpose that the medical staff are actually working towards? Is it the same as the organisational's purpose? The slide I've got on the right there is a sense of coherence when we're looking at alignment, improvement, engagement. Does what we're doing make sense to me? I have what it takes to do this, and that it's worthwhile. So my reflections at the sharp end. My purpose when I did this job was to really go back to my roots and find some direction. It wasn't necessarily linked to the organisation's purpose. I was there for me, really to get myself back into what I thought would be ongoing professional reaccreditation as a consultant, which I basically did after 6 months. In terms of processes followed, it was largely self-organised within the various constraints of the facilities. And really the outcomes out of my 6 months was that, yes, I did become reaccredited as a consultant. I did enjoy myself. I actually happened to achieve management directed goals, even though they weren't necessarily obvious to me. But having my background in management, the things such as patient satisfaction, patient safety, and resource utilisation in particular were important. But after all that, I returned to management practice. And a number of people said to me, oh, that was a waste of your 6 months doing that. But in fact, it wasn't. It actually helped to reorientate myself back to management practice. Now, given the time, I'll just go through some of these slides a little bit quickly. But often this really demonstrates that the organisation's interests and the doctor's interests don't necessarily intersect, and it's how widely they do intersect, which is important, or trying to find the purpose of where these things do intersect. We talk about a whole lot of things in regards to engagement of senior doctors, compacts and the like, and different methodologies with it, but we'll just leave that in the background. Another of the frameworks that I thought was important that I learned about was the tight, loose, tight framework. Now, in agile environments, basically these environments are fairly tightly controlled about what we're actually here to do. The workforce really organises itself, but it's actually tight at the other end in terms of results and feedback back, and the loop of the circle actually completes. There's a lot of innovation in these particular organisations where people come up with different ways of doing things. It's quite different to traditional organisations such as hospitals, where the individuals working with it either don't really know what they're there to do or understand. So you can have a look at different visions and directions and that. And oftentimes when this, except in some of the most successful organisations, it's not really clear. Now, in traditional organisations, it's often tended to be controlled by tight policies, processes and protocols, and junior doctors in particular are quite resistant to that, and I'll tell you why in a moment. And the outcomes is usually not a feedback loop in terms of what's actually being done and aligning it back to what the purpose actually is. What happens with junior doctors is that the organisational purpose versus the self-purpose may not align. And in fact, the purpose mindset may deviate from being initially quite idealistic to one of survival. And when the junior doctors are in survival mode, their overall goals are really to get a training, get an education, and be able to work out anything in terms of different alternate ways of doing things. And then there's no feedback back necessarily as to, okay, what did you do to actually make your life easier? A lot of people want to come in, do the work, go back home and study. So management must focus on influencing the behaviour through personal and structural impacts on the motivation and ability of junior doctors. Given the time, I'll just go through this quickly, but it's actually trying to have, a lot of times the junior doctors really move much more into the job or career mindset rather than actually a mindset which is actually looking at more things about aligning your personal values and goals to that of the organisation. I don't have time to talk about the influencer model, but this is one of the, it took me many years to find something like this. Certainly have a read of the book. You need 4 or more sources of influence in terms of getting change. And a lot of times the junior doctors in particular look at most things from a personal and ability point of view, what they want to do and what they can actually do, rather than actually looking at things within the overall hospital environment. And it's these things in particular about getting doctors to work in teams and being able to work with others, being able to have a facility that actually means something with rewards and recognition. That's where you need to target. And I won't go through this slide, which is the traditional ways of viewing things in terms of outcome measures. So my last 2 slides is really looking at what's real, what management must do. So the lessons overall is that competency training in basic job tasks and ease of finding information is critical. I found that when I returned to the ward, I needed to be upskilled on the drugs, but my practice of rehab medicine was all actually there. It took about 6 weeks really to feel comfortable in the environment and learn sooner. So I had to learn how to actually work in the environment. And I think that's really a number 1 thing for any of the doctors working within the facility. They need to know how to basically do the job and do it the most effective way. Being able to structure teams and environments to improve JMO capacity is important. Reduce the amount of waste time and being able to get doctors to work within teams. Add value by reducing red tape and waste in the system. Providing things in the environment which do align more with the junior doctor's goals, and that's time and support for vocational training and being able to be involved in various change processes. Obviously, work to sustain and align personal purpose with organisational purpose and being able to promote organisational outcomes. So my last slide is areas of research in this. This is an absolutely fascinating area, and being able to understand the complex adaptive hospital environment and how you can actually improve safety with the workforce you have. There's numerous ways to do this, some which are successful, some that aren't successful. So I'll just stop there and just say to everybody, I know the last bit was a little bit rushed. This could be a whole day's presentation, but we've got some things there in terms of models and constructs that people can look at in terms of their ongoing practice.
Thank you very much, Brett. Thank you for sharing your reflections and your experience. It was fascinating, very fascinating. Are there any questions for Brett from the people on Zoom? If you'd like to type into chat or just speak up.
I'm Adam, if that's okay. It's me, Adam.
Yep, go ahead, Adam.
I having had worked with Jeff Braithwaite and Joanne Westbrook for probably about a decade, I know their approach to things, and I understand how they like to work as well. One of the things that I think I see quite a lot from a research perspective is the idea that we can develop interventions in 1 or 2 settings, test them, and then try and write about them for everybody to try and implement in their own settings. The research agenda, the research suggestions that you had at the end, they were quite general and potentially could apply to lots of different settings. So I was interested in what you think about the role of evidence-based interventions for patient safety that come through the literature, the idea of localization for certain settings, or do you think that all of the interventions for patient safety have to be homegrown?
Yeah, well, I think if you start using the words patient safety, oftentimes what you get coming out of people's mouths is pressure injuries, falls, other infections, deep venous thrombosis, complications, assaults, those sorts of things. And there's a whole lot in the quality aspect which includes the effectiveness of care. So certainly in the medical profession, in terms of using level 1 evidence-based medicine and effective and appropriate care is often not the things on the standard safety and quality agendas. So that's number one. The second thing is that a lot of the stuff about ensuring the safety of an organisation is cultural. So the culture of the organisation, your improvement methodologies right across the organisation have to be known, practiced and led. When it comes to individual approaches, I think it's very good to encourage and support practitioners look at anything in terms of low-level quality assurance research to broader levels of research to actually be involved and actually understand exactly what's happening. And as you know, there's a whole lot of qualitative and quantitative domains that can actually enter into. I suppose one of the things that I really put up today is a lot of work to actually improve the capacity of individuals is actually really important. And that's not just with doctors, that's with nurses, so that people can actually spend either more time with the patients or communicate with other members of the team. If we do have chaotic or environments which don't support, a lot of time is spent on, I call on the waste aspect of things, then even if people do have the competence and capability to do the right things, they may not necessarily do it.
Brett, we have a question from Heiko on the chat. So you mentioned a lot in your presentation about IMS and IMS reporting. And Heiko's question is, do you see an area of algorithms being designed into EHRs that can detect adverse events or trigger more detailed manual chart review to determine if there's a real problem as an alternative perhaps to IMS?
No, yes, I do. So recently, I participated in a proof of concept trial with eHealth and the CEC to actually look at a electronic reporting system in terms of actually extracting and pulling things out of the medical record as opposed to IMS. Now, a number of researchers would know that what's in IMS and what happens in practice in terms of incidents can be quite disparate in terms of reporting the same things and a lot of cases. And we found this through this piece of research that we were doing for the past year to be the case. The trial we were doing was something called Pascal Metrics, which is a US-based system, which was essentially looking at the global trigger tools and pulling that out of the system. There's a lot you can actually pull out in terms of data. So the outcome of that we found was that the global trigger tools is really meant to be a retrospective review, a monthly review or so forth of various things that's happened, rather than a proactive interventional aspect, which is what we were actually looking at. What we did find was, though, we picked up a number of incidents and events that didn't actually come through the standard M&M reports or through incident reports. For instance, an algorithm was set up in the system to identify blood loss or HV drop of more than 25% and 50%. And that actually led us to numerous things that weren't actually available to us in terms of the normal reporting. So I think this is the big growth area, that incident reports is really a personal initiative, intervention report or documentation that actually takes a lot of people's time, 20 to 30 minutes. Personally, I'd like to see a lot more come out of the standard record in terms of using templates or extractions, particularly when it comes to falls and pressure injuries and so forth, that can be extracted rather than actually in the individual incident report. I think that would be better in terms of productivity and also documentation up front. But the next big thing is actually being able to extract things from the EMR, and the applicability of that. It has potentially a lot of time savings in the system, such as, for instance, finding, instead of having a nurse employed to look at the presence of crush fractures on x-rays, being able to set the algorithms up to be able to, and people have done this outside of this system, to be able to identify particular words or phrases to actually cut it down and actually have a look at. And then you can pair that up with all various other things in the system. Yep.
Great. Zoe has a follow-up question. Go on, Zoe.
Yeah. Thanks, Brett, for your wonderful presentation. I'm Zoe. I'm a researcher investigating AI for patient safety improvement. My question actually is related to your slides about get the right issue and incidents report. And it's wonderful that you mentioned about incidents report. And I'm interested in incidents report learning using informatics method. So often hospitals use incidents report to capture the progression of medical incidents. So from your experience, do you think that these rights are properly captured in incidents report? And do you support capturing these rights using incidents reports?
Yeah, so I've got to say I'm a little bit cynical about incident reports, only because of really how they're actually used. And look, there's often the critical incidents which end up as SAC 1 or SAC 2s. Yes, very important, and a lot of other things happen with that. The 3s and 4s are often not necessarily captured, depending on what system that you're actually looking at, or they are captured and saying, oh, we've had X number of pressure injuries or falls or whatever else. The big thing is the actual utilisation of the data within a work organisational unit. A number of things, for instance, if nurses do enter a lot of the incidents into the system, that there's a lot of things that need to be actually discussed and actioned at the ward level. And that could either come up in the meetings, or to be able to say, all right, why is it that we're having X number of falls or incidents, and that it's a talking point. It's actually being able to look and own your particular data. So I think the major thing with the incidents is making any of the incidents and that relevant to your local area. From an organisational point of view, looking at, if you like, trends in the system, and certainly disseminating any successes at a ward level area to other ward or units, through other particular mechanisms. Does that answer your question?
Yes, yeah, of course, yeah. Just to let you know that we are interested in developing information retrieval system to automatically capture the rights from incidents report. I know that it depends on the quality of the data, because if you got poor data, it's difficult to develop a good system. But we hope that this project will work, and I would be happy to share our outcome with you.
Yeah, well, that'd be good. And certainly we found with the Pascal metric system that we actually evaluated with the Prince of Wales Hospital for eHealth and the CEC, that often things that were reported in IMS that weren't actually entered in the notes. Things were entered in the notes that weren't reported in IMS. Because people were having to write things 2 or 3 times, there was this disparity in the information that was actually put down. So we would be often better to ensure that we document better once, particularly for standard things, and use that in terms of being able to report it. So certainly the AI side of things and being able to extract or better use of templates, or finding things that you don't know and then incorporating that into the Cerner system is good. So for instance, one of the things, Prince of Wales was looking at acute kidney injury, and they've actually put different algorithms into Cerner to flag through that particular system. We didn't have that system, but we certainly found acute kidney injury through the Pascal metrics, which demanded the use of algorithms to actually highlight particular things to the clinicians. So yeah, this is the way forward.
Okay, thank you so much.
Thank you, Brett. I'm conscious of the time. Adam might want to wrap up. Adam, yep.
Unless there's any last minute questions, then I can certainly wrap up. We'll probably do one more if there's any desperate questions. Otherwise, feel free to annoy Brett by email after the session. I'm sure he'll love that. Okay, so no more questions, and just to let everybody know that the next seminar, Tuesday 11th of August, is with Carissa Bonner, who's from here at University of Sydney, and that will be around something called ChatGP, improving communication about heart disease risk assessment in general practice using e-health interventions. So that should be a fun and interesting one. Thank you everybody for coming, and I'll see you again either in a week or in 2 weeks when the next seminar is on. And Brett, thank you again for your time. Much appreciated. That was great.
Thanks, Brett.
No, you're welcome.
Thank you. All right.
Bye.
Great. So.
All right, that went well, I think.
Yeah, it was really good.
I have a question for Brett, actually.
Yeah.
Go ahead.
I got you up by yourself. I was just interested in your comment about work